All right, welcome everyone. This is Connie Sullivan. I'm the president and CEO of the National Home Infusion Association, and thank you for taking a few minutes to learn about this new pilot program being offered by NHIA to increase access to Bamlanivimab in skilled facility and long-term care facilities. You can go to the next slide. Today, we're going to have a presentation by myself, Bill Noyes, Senior Vice President of Reimbursement Policy, and Ryan Garst, PharmD, Senior Director of Clinical Services. You can go to the next slide. So with this very brief overview, we're going to cover the pilot itself, what the program goals are, what the criteria are for participation, and how you enroll. We'll also review the Medicare billing procedures and how you get involved in serving Medicare patients, talk about patient eligibility to receive Bamlanivimab. I'm going to call it BAM. Let's just do that. And making sure that you understand the conditions of the FDA emergency use authorization, and then review some of the data collection responsibilities for those who choose to participate in the program. And I just want to start by saying NHIA has been very involved with Operation Warp Speed and several other departments within Health and Human Services and CMS over the last several months to talk about how home infusion providers can be more directly involved in administering COVID-19 therapies. And we've been particularly focused over the last couple of weeks on how we can increase access to monoclonal antibodies. And as a result of those discussions, there has been interest on both sides to have home infusion providers play a stronger role in trying to make these drugs more accessible to patients that are in long-term care, skilled facilities, and assisted living facilities. And so we have put together this pilot program to help make those drugs more accessible in those settings through home infusion providers that are interested in enrolling in the program. The main barrier to this happening organically has been that the allocation process for the monoclonal antibodies goes through the states. And unfortunately, states are not always aware of home infusion providers and their capabilities and understand how to connect with those of you who might be interested in providing support for COVID-19 positive patients in these settings. So what we are hoping to do with this program, we have basically two main goals: to increase that access, like I've already explained, but secondly, to identify qualified home infusion providers that are interested in working with the states directly to provide COVID-19 treatments in these settings and potentially in other settings as well. When we get into the details of this program, we'll explain the differences, but this is hopefully a way to help connect states with qualified home infusion providers and help them learn more about the capabilities that you have to serve patients in a variety of different settings that may be underway in your state. So you can go to the next slide. So what is this program? Essentially, HHS is allocating 500 vials of Bamlanivimab per week to NHIA to distribute among home infusion providers who enroll in this program. Now, that's not a lot of product, so not everyone who enrolls in the program will be able to access product immediately, but we do hope that over time we can distribute product to most providers that want to participate. Once you receive product, if you are allocated product, then we would like for you to reach out to the facilities that are in your service area and offer to provide BAM infusions to eligible patients and also to staff in those facilities. Now, a lot of these patients will be Medicare patients or Medicare Advantage patients, and therefore the providers that participate in this program need to be able to bill through the ABMAC for monoclonal antibodies, which is running through the COVID-19 vaccination program, and Bill's going to talk more about that in a few slides. And then also what NHIA will be doing is creating a database that states can access to learn more about who are home infusion providers that are interested in participating in treatment in providing treatments for COVID-19, and then hopefully connecting you directly with states to obtain additional allocations. You can go to the next slide. We try to keep this very simple in terms of who can qualify to participate in this program. Essentially, it is open to both NHIA member and non-member pharmacies as long as you can meet these criteria. The criteria include being a licensed pharmacy in good standing, being accredited accredited for home infusion, and that accreditation is the standard home infusion accreditation you would typically use to credential yourself with a commercial payer. You have to be able to bill CMS for the vaccines through the immunizer program. You also have to do everything you would normally do for a home infusion patient. Do your assessment to make sure they qualify under the emergency use authorization approved by the FDA, obtain physician orders, coordinate nursing services to administer the product, dispense, deliver, etc. And we are building some additional tools to help you facilitate some of those processes. Also, there is some data collection that we hope to accomplish with this program. Obviously, how long this program goes on for is going to be somewhat dependent on our success with getting product out to our sites and then having the sites get that product into the SNF and into patients. So we want to be able to collect some data to demonstrate that success and also provide some outcome data potentially in the future. And then finally, we do ask that all participants of the program sign a very simple participation agreement that's very straightforward about roles and responsibilities. Next slide. From a home infusion provider standpoint, some of the things we ask of you is obviously if you are allocated product to really work to try to get that product into patients that are at high risk and qualify that are living in long-term care facilities or assisted living facilities in your service area. So that obviously will take some effort, and we are also trying to work with other partners of NHIA to get the word out to the SNFs that this is an eligible program that they could hopefully participate in as well. Obviously, you're doing everything I just talked about in terms of assessments for eligibility and coordinating the care. We do hope that you would make every effort to perform infusions within 24 hours of receiving a qualified referral. And obviously, we know that's not possible in all cases, but again, we would like to stress that you're working mostly locally with your facilities that are in close proximity to your location. We also want to be able to list your company name and location and contact information on the website so that we can share that with states that are interested in potentially expanding access to these products through home infusion providers and other ways. And then obviously we'll be collecting and submitting the required data back to HHS. I'm sorry, this one is that you'll be submitting the data to NHIA, and we're going to run that data through the foundation, and then we will put that, send that on to HHS. Sorry about that. Go forward. Next slide. So from an NHIA standpoint, what we see our role in this process is to hopefully just connect home infusion providers with state health departments so that they can facilitate other programs where we're getting these monoclonal antibodies out to patients who need them. We're also facilitating the allocation. So once we have the information we need from participants, we will be sending that directly to HHS so that they can allocate the product through AmerisourceBergen. So again, this allocation does not run through the state, so it's a little bit different process. NHIA will obviously make every effort to ensure equitable distribution of the products across all the jurisdictions within HHS and prioritize access for rural and underserved populations. Our goal is to try to fill gaps. We know there's already other pilots going on. We know that there's product out there that some may be accessing through other programs. So we do have a questionnaire as part of the enrollment process to try to learn where product is already maybe in the hands of some providers so that we can prioritize other areas that maybe can reach patients who don't have access to these any other way. And then finally, we'll be in close communication with HHS regarding the status of the program and, like I said, sharing back data that can demonstrate the success of it. So that's my portion of this. I'm going to turn it over to Bill Noyes to talk a little bit more about enrollment and how you bill for services.
Thanks, Connie. Billing for services in a skilled nursing facility normally is billed directly by the skilled nursing facility. But for COVID treatments under this program, CMS is allowing other entities to bill directly for services provided in the SNF. I thought that was important to point out. That's an exception to the normal rule. For anybody to bill for COVID-related treatments, they're treating the monoclonal antibodies like a COVID-19 vaccine. So all of the same rules and enrollment apply to the monoclonal antibodies as do the vaccines. There's a lot of information out there. We're going to point you to where to find that directly, but you must be enrolled with the ABMAC to bill for these services. You can't bill them through the DME-MAC. CMS has cast a wide net as to who can provide services. And if you're not currently enrolled with the ABMAC, there's a process that you can go through to get quickly signed up as a mass immunizer, which will allow you to bill for the monoclonal antibodies. This is based on the facility address of your licensed pharmacy. And again, I don't want to get into a lot of details on this call, but we do have references for you. As far as the rate for the administration, the allowable that CMS has set for administration of BAM is $309.60. This includes all equipment and supplies necessary to administer the drug itself. The drug would not be included on the claim as it is provided free at this point. If there comes a time where the BAM is a buy and bill, CMS will pay 95% of AWP, and in that circumstance, they would update the allowable on this slide to reflect whatever 95% of AWP is at the time. NHIA is putting together a list of resources regarding this pilot program, and those resources include a one-pager that we put together that walk you through enrollment, billing, coding, and the documentation requirements. The documentation you want to make sure you have on hand to support the billing of these claims. And with that, I'm going to turn it over to Ryan to review some specific clinical information and data collection.
Thanks, Bill. As we've probably heard, BAM is indicated for adults and pediatric patients over 12 years of age and 40 kilograms that are considered high risk with a progressive or potential to progress to severe disease or hospitalization. So one of the qualifying criteria is for the program is to be able to identify these patients. So again, the high risk for adults is considered a BMI greater than or equal to 35. 65 years of age or older, chronic kidney disease, diabetes, immunosuppressive disorders or patients taking immunosuppressive agents, or patients that are greater than 55 and have one of the following: cardiovascular disease, hypertension, COPD, or another chronic respiratory disorder. For pediatric patients 12 to 17, their BMI must be greater than or equal to 85% or equal to the 85th percentile based on the CDC growth charts. They would have sickle cell disease, a neurodevelopmental disorder, or a medical related technology such as a G-tube or trach, or again, an asthma or another respiratory disorder that requires daily medication for management. Won't go over all of the specifics here, but you can see the dose is 700 milligrams. And again, we would like the medication to be delivered or administered within 24 hours of receiving a referral. But again, the guidelines in the EUA are within 2 days of a positive test and within 10 days of symptom onset. Basic adverse events that have been noted this far are nausea, dizziness, and headache. Preparation and storage, you can see here the vial comes in a 700 milligram per 20 ml. Currently on this slide are the EUA recommended compounding instructions with storage. However, Eli Lilly last week released a new technical document that can be found on our website, and that it is essentially to address alternative options for preparation administration for providers that are going to be administering Bamlanivimab. So you can take a look at that. It gives some additional clarity to what's in the EUA. And again, that will be posted. But high level, does need to be infused with an inline 0.2 or 0.22 micron filter via gravity or pump over at least 60 minutes, a post-infusion flush with 50 mLs of normal saline to ensure the entire dose has been infused, and a 1 hour post-monitoring period after the infusion. Next slide. One of the major requirements of the FDA EUA is identifying and reporting serious adverse drug reactions. So wanted to talk really quickly about what that is and how it's defined in the EUA. So again, defined as any adverse event that is undesirable and results in any of the following: death, a life-threatening adverse event, and in this case, an inpatient hospitalization or prolongation of existing hospitalization. So in this situation, these patients are in long-term care facilities. So if indeed they received a dose and then got admitted and they thought that it was potentially related to the infusion, a persistent or significant incapacity or substantial disruption to the ability to conduct their normal daily functions, that would be something you would have to assess with your long-term care facility partners based on the patient. Congenital anomaly or birth defect, and a medical or surgical intervention to prevent death, a life-threatening event, hospitalization, disability, or again, congenital anomaly. So this is how it's defined. So next slide. And this is how it's required to be reported. Again, it is a condition of both the EUA and participation in the program. And only serious events are mandatory to be reported. Again, through the FDA MedWatch program, Form 3500. There is a link here for the instructions on completing the form for healthcare providers. There is also in the online form, it can be done online, or you can download a paper form and fill it out and submit it to an email address that's listed on the website. And any of these events that are suspected to be potentially related and are serious, again, serious events only need to be reported, must be reported within 7 days of the suspected event. Next slide, Bill. So as Connie mentioned, in terms of outcome data collection through the foundation, while it's not going to be mandatory, we are strongly encouraging participants in the program to be able to gather and submit data to show the value of the program. However, there are going to be certain things that do need to be documented, such as the name and address of the facility where the drug was administered. Also, the qualifying criteria, and we do have a tool that will be recommended to use. You don't have to use it, but it's an example order form that does list all of the criteria that would qualify a patient. So identifying high-risk status and all of those types of things, and we'll have that available, again, posted to our resource center. Additional information and all of that qualifying criteria needs to be documented. So all of that to make sure and ensure for billing purposes, as Bill mentioned, to make sure the drug is going to the appropriate patient per the EUA. Additional things that we're looking to collect would be patient age, gender, and ethnicity, and then also a 7-day touch point to collect some outcomes such as adverse events, such as moderate, that are typically documented in the nursing notes or another way of documentation. Again, not anything that would be serious, because those serious events would be, again, reported to MedWatch. But mild to moderate events, just from a data collection and outcomes perspective, any hospitalizations, ER visits, and or death. Again, ideally, it's not going to be required, but we would like to gather some of this data to show the value and overall success of this program. Next slide. And again, for more information, we do have a pilot program website. You can see the link here that will have all of the resources, including this recording. And as we build new resources for you all to participate, that will also be there. And then we will be holding office hours on Fridays from 10 to 12 p.m. Eastern while the program is going on, just as an open forum for any question and answer, hear about some success stories or any challenges that anyone's having. And again, you can register here at the link that's provided in the slides. So with that, we'd like to say thank you for spending a few minutes of your day to get more information on the pilot program. Again, if you have any questions, you can get in contact with us at info@nhia.org, or reach out to any one of us that you know, and we can certainly get this program up and running. We're looking forward to it. I'll turn it over to Connie if she has any last comments.
Thank you all. We just appreciate your taking your time today to review this important information. Again, just reach out to info@nhia.org for any further questions. Thank you so much.